Ladies and gentlemen, thank you so much and welcome back to our presentation. Today we are going to look at the Tetralogy of Fallot. And even before we proceed, guys, we just want to thank you as a channel. Thank you for the support you've been providing to us by liking the videos, commenting on them, and sharing with others. All right. So let's proceed with the Tetralogy of Fallot. Okay, this is the most common form of cyanotic congenital heart disease. And when we say cyanotic congenital heart diseases, these are conditions which normally decrease in oxygenated blood circulation. Okay, decrease in oxygenated blood circulation, and this normally leads to the patient to present with bluish discoloration of the skin that's documented as cyanosis. A cyanotical, on the other hand, it's a situation where oxygen-rich blood will mix with oxygen-poor blood. So you find that cyanosis may not be as apparent as such. All right. Examples of conditions which have cyanotic kind of, where there is decrease in oxygenated blood circulation, include the one that we are going to focus on today, the Tetralogy of Fallot, along with transposition of the great arteries, the tricuspid atresias, the total anomalous pulmonary venous return. On the other hand, we have conditions like atrial septal defect, the ventricular septal defects, patent ductus arteriosus, and coarctation of aorta, where just oxygen-rich blood will mix with oxygen-poor blood, and cyanosis is not apparent as such. All right. So that's how those two conditions normally differ. So guys, so how is the blood circulation in the heart normally happen, right? So of course we all understand that the heart is a muscular organ which is responsible for pumping blood throughout your body. So blood circulation in the heart normally follows a precise pathway that starts with the right atrium. Okay, so the right atrium, we can all observe it from here. Okay, we can all see the right atrium at that point. So we have deoxygenated blood from the body will return to the heart, and this is via the superior and inferior vena cava. Then it enters the right atrium. Now from the right atrium, blood will flow through the tricuspid valve to the right ventricle. Then the tricuspid valve, its sole responsibility is to prevent the backflow of blood into the atria when the ventricle contracts. So when the right ventricle contracts, it will pump this deoxygenated blood through the pulmonary valve into the pulmonary artery. Now, the pulmonary valve ensures that blood flow is in one direction, so it prevents the backflow into the right ventricle. Okay, so the pulmonary artery normally carries deoxygenated blood to the lungs. Right, so where now it will pick up oxygen and will release carbon dioxide. Then oxygenated blood will return to the heart through the pulmonary veins entering the left atrium. So you can be able to see that the right atrium. Okay, and that's what happened in that case. So in this case, at this point, this is oxygenated blood. Okay, so from the left atrium, oxygenated blood flows through the mitral valve or the bicuspid valve into the left ventricle. Similar to the tricuspid valve, you find the mitral valve prevents the backflow of blood into the atrium from the ventricle when the ventricle contracts. So when the left ventricle now contracts, it will pump oxygenated blood through the aortic valve and into the aorta, which is the body's major artery. Right? So the aortic valve will ensure that blood flows from the left ventricle into the heart and will prevent any backflow into the heart. So from the aorta, oxygenated blood will be distributed throughout the body, and this will help deliver essential nutrients and oxygen to tissues along with other organs. Then deoxygenated blood again will return to the heart through what we refer to as the superior vena cava and inferior vena cava, and the cycle continues. So that's what happens in a normal circulation. But in the case of Tetralogy of Fallot, We have four definitive defects in this case. We have ventricular septal defect, right ventricular outflow tract obstruction, right ventricular hypertrophy, and dextroposition of the and the dextroposition of the aorta. So these four structural abnormality will affect and alter the pathway, okay, or the pathway. So for the ventricular septal defect, you find that there will be a hole in the wall, that is the septum, that normally separates the two chambers of the heart, that is right and left ventricles. So this ventricular septal defect allows oxygen rich from the left to mix with the oxygen poor from the right? And you find that this on its own, it can lead to a cyanotic condition, all right? Okay, then number two, now we have now this overriding aorta, all right? Overriding aorta. Remember, we have this ventroseptal defect here. Now we have this overriding aorta here, all right? So what does this overriding aorta entail? If you know, of course, we know that the aorta is the main body's main artery, so it will be shifted to the right, okay, and positioned directly above the ventroseptal defect. So this will cause the aorta to receive blood from both ventricles, right and left, and this will lead to mixing of oxygenated and deoxygenated blood being pumped to the body. The third one is pulmonary stenosis, and this is narrowing of the pulmonary valve or the pulmonary arteries. So this will obstruct flow of blood from the right ventricle to the lungs, okay? This obstruction increases the workload of the right ventricle and limits the amount of oxygen poor blood reaching the lungs for oxygenation. We have to know that this pulmonary stenosis is the major cause of reduction or hypoxia in that case. Lastly, we have the right ventricular hypertrophy, and the right ventricle will become thickened and enlarged, and this is majorly due to increased workload caused by the pumping of blood through the narrowed pulmonary artery or the artery or the valves. All right, so and all these causes will lead to the tetralogy of Fallot. Of course, the exact cause is unknown, but it could be a variety of conditions, okay, that normally leads to this. So in tetralogy of Fallot, we have the blood will shunt from the right to the left, and this will be through the ventricular septal defect, and this will permit an oxygenated blood, the oxygenated blood on the right to mix with oxygenated blood on the left, and this result into various degrees of arterial desaturation. Subsequently, desaturated blood will enter the systemic circulation. So this condition sometimes will coexist with other congenital heart defects like the patent ductus arteriosus and the arterial septal defect. However, the research has shown that genetic research indicates that copy number variants or a major source of genetic variants that contributes to many of these diseases could contribute to development of the tetralogy of Fallot along with other conditions. So we have several risk factors that could increase the risk of someone developing this condition, like the poor maternal nutrition during pregnancy, viral illness, especially the maternal rubella, advanced maternal age, maternal alcohol use during the pregnancy, some of the genetic disorders, and maternal use of retinic acid or oral fluconazole in the first trimester, along with maternal diabetes, will predispose this patient to developing this tetralogy of Fallot. We could also have presence of a chromosome disorders like the Di-George syndrome or the Down syndrome, or the Kobola, the heart defects, other atresias or retarded growth, genetic abnormalities, all ear abnormalities will present along with this condition, right? The Baxter syndrome, on the other hand, like the vertebral defects, the anal atresia or imperforate anus, the cardiac anomalies, tracheoesophageal fistulas, the renal anomalies, lymph anomalies, and family history of tetralogy of Fallot will also double the risks. In terms of incidence of tetralogy of Fallot, I find tetralogy of Fallot accounts for approximately about 7 to 10% of cases of congenital heart disease, and the prevalence of tetralogy of Fallot is estimated to be around 1 in 3,000 live births. It is the most common cardiac anomaly that is normally diagnosed in the first year of life that will require surgical interventions. So incidence normally increases with increased maternal age, as we have indicated in the risk factor. When you try to compare the males and females babies, the condition occurs equally in males and females, or the survival rate for the past 10 years is about 92%. Tetralogy Fallot normally comes up with several complications like the cerebral abscess because of low perfusion, the erythrocytosis from chronic hypoxia, acute arthritis, delayed puberty, neurodevelopmental impairments such as the cognition will be affected, the speech, the motor functions, and patients could even present with the neuropsychiatric symptoms. For the post-operative complications, we could have residual right ventricular outflow obstruction, the ventricept or the ventricular septal defect. Could also have chronic pulmonary regurgitation, ventricular and atrial tachyarrhythmias, right bundle branch, infective bacterial endocarditis, and hospital-acquired infection. If it's untreated, you could have the blood clots, which might cause stroke, or bacterial endocarditis, heart failure, and even death. So when you have the patient, we have to do assessment, and in assessment we have to start with history taking. So we try to look at any hypercyanotic spells, the ones that are commonly referred to as the TET spells, or like in the middle of an exercise or an activity, a patient could develop problems with breathing and start being having bluish discoloration. That should be picked up as the TED spells, or could have diminished exercise tolerance, where in middle of an exercise they run out of energy and of course almost oxygen, that they are not able to tolerate the activity further. We could have increased dyspnea on exertion also, along with the history of growth retardation, delayed development, and even eating abnormalities. If you perform your physical assessment, you could observe the patient has clubbed feet, right? Or cyanosis if there is severe right ventricular outflow, that is the obstruction. Otherwise, they could be acyanotic, right? We could also have dyspnea on exertion or squatting position that after exertion or during the TED spells. We could also have a loud, harsh, crescendo decrescendo systolic heart murmur, and this is best heard along the left sternal border, which may diminish or obscure the pulmonic component of the S2 or the S2. All right, so that should also be noted. We could also have a cardiac thrill at the left sternal border and an obvious right ventricular impulse. Remember, our problem here, we have the pulmonic stenosis, right, which will be found, of course, on the left, and that's why we can be able to get that. We could also have early systolic ejection sound and the crescendo decrescendo systolic ejection murmur, and this is due to flow across the narrowed right ventricular outflow tract, and then we have a prominent inferior sternum. So what are some of the tests that we can do? Starting with laboratory, we could do arterial oxygen saturation, and you find that arterial oxygen saturation will be diminished. The patient could also be presenting with polycythemia, And we could also find that the hematocrit test may result in may be more than 60, and the platelet count could be low. Fibrinogen blood test and coagulation test factors are diminished, while the prothrombin time will be prolonged. In terms of imaging, we could do the prenatal ultrasonography, and this could help to detect tetralogy of Fallot in utero, or the chest radiography, which may demonstrate an increased pulmonary vascular marking depending on the severity of pulmonary obstruction. Okay, so we could have a boot-shaped cardiac silhouette or a prominent right ventricular. So that will show that the right ventricle has done what? Has enlarged, has hypertrophied. We could also do the echocardiography, which helps to identify the septal overriding of the aorta and the ventricular septal defects, along with pulmonary stenosis and defects that that will detect the hypertrophied walls of the right ventricle. MRI could help in identifying structure and provide information about intracardiac pressures and blood flow. Then on the transthoracic echocardiography could reveal the defects. So we have electrocardiography, which may show right ventricular hypertrophy, right axis deviation, and possibly right atrial hypertrophy. For cardiac catheterization, it will help to confirm the diagnosis by showing the pulmonary stenosis, the ventricular septal defect, and the overriding aorta, and by ruling other synetical heart defects. All right. In terms of treatment, we could start with the general, where we can do prevention and treatment of complications. So that during TET spells, we normally do the knee chest position, and we also administer oxygen and morphine just to improve oxygenation. In terms of activity, we could encourage activity as tolerated, and that should be appropriate for that age of that child. In terms of medication, we could do oxygen just to increase perfusion and oxygenation, along with morphine sulfate IV for pain during severe TED spells, and also you could give digoxin just to regulate heart rate. Okay, of course, remember digoxin is a cardiac glycoside. We could be able to access the link and get more information about the digoxin. As for furosemide, this is just used to manage the fluid overload, and this is what? This is a loop diuretic. You can also access the link and get more about the loop diuretics. We could also have antibiotics, and this will help to treat infection, along with IV beta-adrenergic blockers, all right, or the phenylephrine, which is if first-line methods will fail, then you can have that one. Okay. Also for the beta blockers, you can also access the link and just see how they do. All right. The surgery, you could do palliative surgery on infants with potentially fatal hypoxic spells, and the goal being to enhance blood flow to the lungs and to reduce hypoxia. Commonly accomplished by normally joining the subclavian artery to the pulmonary artery, and this is normally referred to as the Blacklock-Towson-Thomas procedure. So you complete intracardiac corrective surgery, which will relieve pulmonary stenosis and close the ventricular septal defect, then redirect left ventricular outflow into the aorta for that case. So as a nurse, you need to assist the patient in the knee chest position when the child is experiencing a TED spell. Okay, I think it will be popping up on how to help the patient into a knee chest position, right? You also need to complete a fall risk assessment, that is preoperatively and postoperatively, and then you institute the necessary measures about the same. You have to prepare this child both physically and emotionally for the procedure, then allow the child and the family to verbalize any concerns and anxiety related to the conditions and surgery. Then you have the obligation to actively listen and answer any questions honestly. You have to provide clear communication and explanation about the care and the treatment plan, and you cluster nursing activities so as to minimize energy expenditure and also provide frequent uninterrupted rest periods. You have to encourage the use of energy conservation measures and then always maintain a patterned airway for the child. You also have to administer oxygen as prescribed and based on also oxygen saturation level that's obtained via the pulse oximetry or use of the arterial blood gas analysis. You also have to administer prescribed medications and monitor their effect, like morphine, for example, for that case, Lasix or digoxin. You also have to institute continuous cardiac monitoring as indicated to evaluate for arrhythmias, and also you have to provide postoperative care including frequent monitoring and surgical site care. Encourage the family's participation in the child's care and decision making, and maintain infection control precautions including hospital acquired infection prevention bundles, and then hand hygiene both preoperatively and post-operatively. Always consult with a child life specialist to provide age-appropriate distractions and support, and this can be looked at when looking at the milestones. Arrange for spiritual care at the parents' or family's request, and collaborate with social services to provide counseling, community resources, and support. You have to monitor the vital sign, the cardiac status, the TED spells, oxygen saturation, and also the post-operative status, the surgical site, and also the coping procedures. Remember, you have to perform a number of procedures as you take care of this patient. But post-operatively, you have to look at this neonate, you have to look at the pulse assessment, pulse oximetry, respiratory assessment, temperature, venipuncture, and even the wound care for that case. All right. So that is what you need to look at for this child as you help. But the best thing for this one, as a nurse, you have to know how to position this child in the knee chest position. Alright, so that marks the end of our session, guys. You can get to the description section of this video and you attempt the free quiz just to test your knowledge and reinforce your understanding about the tetralogy of Fallot. Thank you.